So thank you again for this invitation to this lecture. So I will present our experience on the monitoring of EAdi in infants. And my conflict of interest have not changed this morning. I just will begin with the monitoring EAdi that we use as a tool to adapt the level of ventilatory support. As it has already been mentioned several times today, we have to find an equilibrium between an insufficient support, which will preclude the muscle recovering, and an excessive support, which will favor diaphragm atrophy and which risks to prolong the ventilation. So, but in clinical practice, in fact, we don't have many tools to estimate if our support is optimal. And that's why we think that with the arrival of this new method, it would be interesting to use that method to evaluate the impact of the ventilation on this on the activity of the diaphragm. And so we conducted we are conducting presently a study which is a sub-study of the study on the evaluation of asynchrony that I presented this morning, and we repeated the recordings of EAdi and of pressure of the ventilatory pressure at several times during the PICU stay. And in fact, we conducted the first recording in the acute phase, when the patient was able to breathe on his own, at least, higher than the respiratory rate. And the second and the third recordings were done just before and a few hours before and a few hours after the extubation. And then we did a last final recordings after, just before the patient leaves the ICU or the feeding tube needs to be removed because the patient doesn't require the tube anymore. So to date, we have 39 patients in the analyzed, and they all were on conventional ventilation in the beginning. And this is the evolution for the median value of the peak EAdi in the group. And you can see that when the patient, as compared to the final period where the patient had no respiratory distress, or at least no significant respiratory distress because they were leaving the ICU, the median value of EAdi was around 13, 15. And as compared to this data, in the acute phase, the median value was only 4 microvolts. And I was really surprised that almost 1/3 of the patients had no activity at all. And I am even not capable to evaluate the synchrony because there's no activity at all during 30 minutes of recording. So I was really surprised, and I asked the doctors who were taking care of the patient at this time, because I was not always the physician in charge for this patient. And this was not planned this was not desired by the physician at this time. They all were thinking that the patient was breathing during that period. So I think this is really important. And as I mentioned this morning, this low level of EAdi was also associated with a very high level of asynchrony, which is not surprising. And another important findings we observed is that the low level of EAdi is of course observed in some patients with high level of support, which is not surprising. But you can see that even at low level of support, we have some patients with very low level of EAdi. And this is an example of one patient for whom we have done the recordings during the extubation period. She has no lung injury, and that probably explains why she will act like that. But during the period of pressure support, she has only 7 centimeters of water of pressure support, and I think everybody before the EAdi recordings would consider that it's a minimal support. And you can see that she didn't need to breathe at all during that period. And it's not a problem of recordings. When the patient is extubated, the EAdi will appear. And I think that it's really surprising, and we can wonder what happens to this patient during that period. This patient did well, and the activity recovered really fast, but probably if we have the same action on patients with neuromuscular deficiency or whatever, more chronic disease, we are probably injuring their diaphragm. So we really think that EAdi recording could help to see how the patients are reacting to our ventilation. And without this monitoring, we have no idea of the real ventilation of the patients. Is it a good tool to predict the extubation outcome? And the subject has been discussed earlier by the two preceding presentators, so I will be rather short, but I just have to comment on one study which has been published in the pediatric field by Gerhard Wolf from Boston. And he described some surprising findings, because in fact, the ratio of the tidal volume of the delta EAdi was higher in the patient who failed the extubation readiness test. And it's a bit counterintuitive, because as described by Dr. Liu, probably it makes more sense that the opposite would be observed. And so we have to think of why such observation has been made. And I think the problem is that even if they try to standardize the extubation readiness test, it was not, because they used different level of pressure support. And with the light of the findings that are observed during pressure support ventilation, you can understand that some patients react very differently at the same level of pressure support, depending of their lung compliance. And so I think that in some cases, in fact, this ratio in pressure support ventilation really measure the neuromuscular efficiency of the ventilator rather than the patient. So I think that a better approach would be to study this ratio without any level of support. A few words about tonic activity. It has been discussed a bit yesterday, but this tonic activity is really interesting in pediatric patients, and specifically in infants. And we described a few years ago that in a small series of 16 infants, just not really sick, they were just ready to be extubated, that when compared to the inspiration period, all the babies exhibit some degrees of tonic activity. At least 15% of the inspiration activity was persistent until the end of the expiration. So it was present in all the babies, but it was not continuous. It was very highly variable, and it has been reproduced by Jennifer Becker more recently. And this activity is well known to be involved in the maintenance of the end expiratory lung volume above the relaxation volume, which is very low in infants because of the high compliance of their thoracic wall. And so it's really important for them to maintain this end expiratory lung volume. And this is one mechanism that they can use to do that. And one of our surprise in the more recent study was that we observed some tonic EAdi in the infants, and it was not surprising, but we also observed some degree of tonic EAdi in some patients more older than 1 year of age in this patient, and even in the adolescent, we have some degree. It's the mean value of EAdi, of tonic EAdi, so it was a bit surprising, and maybe it's an activity mechanism that can be reactivated in some pathological condition. It has been described in adults in the 80s in Germany, I think, in adults with asthma. So we have to study that. And just if it's reflect of the efforts of the patient to maintain the end expiratory lung volume. It can be a tool to alert you that, for example, the PEEP level is not appropriate. And this is an example that I observed whether it was not really planned to observe this patient. I just arrived to record the patient for the asynchronous study. And in fact, when I arrived, the patient was not so well. He was on the FiO2 at 90%. He presented a desaturation while he was on PEEP at 7. And I didn't know really the patient, but when I connected the catheter, I observed a very high level of EAdi, and you see that the black part is the tonic activity. So he had 10 microvolt of tonic activity. So I called the physician in charge of the patient, and we discussed, and we tried to increase the PEEP, and you can see that immediately. Maybe it's an hazard. I would not say that it's only the PEEP, but typically it decreased rather fast, so it was interesting. And one other aspect of the EDI monitoring, which I think is really interesting, is to monitor the diaphragm recovering or worsening. And in fact, Alice Bordesoul yesterday presented this study for about 2 cases of diaphragm of infant botulism, which is a pathology where the patient is like under a muscular paralysis. And we were able to show the reappearance of the diaphragm activity. And for the second patient, we waited this recovery before the extubation. And it was interesting in this rare disease. And we now routinely use in no units the monitoring of diaphragm activity to monitor the ventilatory drive of patients we think really critical, and especially the patient with neuromuscular disease or patient with Guillain-Barré syndrome or transverse myelitis, neuromyelitic ortica. These patients that are in your ICU and you don't know if they will need to be intubated or if you have to increase to change the treatment to go to plasmapheresis or something. So every day we conduct some daily monitoring in the same condition. If the patient is intubated, we put him on a small level of support, and every day we will see if the EDI is reappearing or if it's worsening, and it can give us some indication. And it's particularly crucial in this patient, if they are intubated, to maintain a certain level of activity of the diaphragm also. So I think that the EDI is a really useful tool to guide the intensivist. It permits to detect the over assistance and to adapt the support of the ventilation, even if it's not on NAVA. It permits, of course, to detect the asynchrony, and maybe it will help to evaluate the extubation readiness, but it has to be more studied. And it's interesting maybe to give some information on the EELV control. Thank you very much.